So we will now move to talk from Professor Helio Rubens Machado. Professor Machado is a doyen of pediatric neurosurgery, one of the foremost neurosurgeons in the world, but also one of those founders of the modern pediatric neurosurgery, along with Professor Salamova and Nelson Zanen, of the proud Brazilian neurosurgical tradition, pediatric neurosurgical tradition. His passion is epilepsy surgery, and Professor Machado, I look forward to hearing your talk. Thank you very much, sir.
Thank you, Nari. Thank you very much. It's a real pleasure for me to be here among these people that know and admire Jim Goodrich. And I can say that I knew Jim Goodrich for more than 20 years, 25 years, and he was always a very special person. What happened is that in 2018, I had a difficult case. I had this set of craniopagus twins, and knowing the interest of Jim with these cases, I asked him to help me. And he came to my hospital, and that year 5 times, and we had a lot of time to discuss, to exchange ideas, and he showed me how to do that surgery, all the details, and all the how to perform the staged separation of these children. And you can imagine that this was a real success. Here we are, Jim, Camila came also, with the parents of these children. It was a real success. And this photo is 1 year later, the children at the beach in the north of Brazil. This was Jim, and was inspired by him that I chose this topic. Jim always encouraged all of us to do different things or complex things. So my idea is to discuss with you, with all the people who are listening, though the pediatric neurosurgeon has to be involved in these cases of difficult case of epilepsy surgery in children. I think, yes, I'm going to try to demonstrate this. This is the outline of this talk, starting the indications of these cases, the types of surgeries, the outcome, and finally the recommendation of the International League Against Epilepsy concerning how to do, how to run a specialized center in these cases. So the first thing that we have to know, the pediatric neurosurgeon has to know, is that surgery should be indicated very early in this, for these children. And this will preserve their brain. You can see, based on our own experience, from the beginning of our experience to the last cases, that we are moving toward the very small children, especially under 2 years of age. This only can be done if you have training, special training in doing surgery in these small children. Why we do that? Because epilepsy in children is comes very, very early and becomes refractory very early, and this is important. So no more than 2 drugs today are 2 drugs as treatment are allowed for these children, because after that, you will not have control of these seizures. So you define this refractoriness very early. As soon as the child arrives, you cannot go trying every new drug that appear every year. We all know that with small children, you have a major risk because you're dealing with complex surgeries, large craniotomies, big exposures. Sometimes the brain is distorted. We'll discuss a little bit more about that. But also because of the anesthesiology problems or even surgical problems doing surgeries in these patients. And one of the complications is very known to us as a pediatric neurosurgeon, is hydrocephalus. Certainly there are other complications, but this one may be quite common. You see that can come up to 80% of cases, depending on the technique that you use to treat these patients, especially in hemispheric surgery. This, you know very well, hydrocephalus is very known to pediatric neurosurgeon. What about the types of surgery that we do? We know that the temporal surgery is done in most of the adults, and 75% in our own experience in adults. And this temporal lobe surgery are performed in only 20% of children. And even in those 75% of cases, in the majority of cases in adults, they are related to mesial temporal sclerosis. And this is not true in children, only half of these children, and we discuss this later. Concerning the pathology, as I mentioned, temporal surgery, mesial temporal sclerosis is the main type in adults, not in pediatric patients. Cortical dysplasia are by far the more common, followed by tumor and gliosis. And what about the types of surgery? Contrary to adults, the temporal lobectomy is the number one in these cases. For us, we see more and more complicated cases. So hemispheric surgeries are the number one in these patients. This is not in every world literature. But anyway, in the centers dedicated to epilepsy surgery in children, this is becoming the real, the first kind of surgery that we perform. If you add to these cases, to modify a little bit this statistics, you see that the disconnective surgeries, we learn disconnective surgeries for epilepsy in children, for instance, disconnecting the frontal lobe or the parieto-occipital lobe, the posterior quadrantic, after we learn hemispherotomy. And if you consider this as the techniques that we use commonly in epilepsy centers, you see that in 40% of the cases, we are doing some kind of disconnected surgery, followed by lesionectomy or expanded lesionectomy. And then third is the temporal lobectomies in these children. And the hemispherotomy, the technique that we commonly use, is the lateral approach, traditional, described by Villemir and modified by Shimizu to disconnect the whole hemisphere. The cases that we see, the Sturge-Weber syndrome is one of those cases. And although the aspect of the brain is terrible, it's scary, that the surgery can be done quite easily. In Rasmussen encephalitis, in spite of the small ventricles, we can also perform this kind of technique. Porencephaly is a kind of porencephaly. Nature has already done most of our work, and this is a very beautiful and straightforward technique in these cases. Other more complicated cases are the hemispheric cortical dysplasia, as in these cases of polymicrogyria, disseminating the whole hemisphere, or the rare cases of tuberous sclerosis in which the whole hemisphere can be compromised. Hemimegalencephaly is must be cited apart because it's so difficult as a technique. In fact, in these cases, the brain is totally distorted, and it's a real challenge for the neurosurgeon. The brain is distorted, the veins, the cortical vascularization is quite complex, you can see sometimes you have the temporal lobe or the frontal lobe very big, and this is fibrotic, and this is very difficult for the technical point of view. Or in the deformation of the midline in this tough brain, that is difficult really to disconnect. That's the reason why in some centers this technique, the hemispherectomy, is still performed. But remember, hemispherectomy, the rate of hydrocephalus is much higher than in cases of hemispherotomies. But results can be fine. Even if you see 5 years later, you can have good results in more than 60% of these children are doing fine in cases of hemimegalencephaly. Just an example of what means by disconnective surgery in this small child, 1 year and 8 months old, with this dysplasia in the posterior quadrantic, and disconnection, as you can see here, is a complete disconnection of the posterior quadrantic lobe of the brain. This we'll see that the brain is still in place, good vascularization, and the incidence of hydrocephalus is very low when you use this technique. Another thing that is peculiar to this to children is the need for intracranial EEG recordings. At least 1/3 of our children will need some kind of intracranial recordings. Majority we can operate on simply with electrocorticography, ECOG, but more frequently you have to rely on these plates and or this means big surgeries to implant this plates or strips. For instance, in this child, a 64 contacts grid is because we're dealing with the left hemisphere in this child, and we must make motor recordings and language recordings before proceed to disconnect, or to, in this case, to resect the cortical dysplasia that was type 2B. The other thing is frequently now, we tend to use now in the last, let's say 5 years, one technique that was described some 50 years ago in Paris by Jean Talleyrand and Jean Banco, that is stereo EEG. It's quite different from the grids that we implant over the cortex. This you can study in a three-dimensional fashion, the network that will give you the idea of the propagation of the seizures and plan your surgical technique. For instance, in this case, the MR was interpreted as normal, but you can see a small alteration in the sign. And for this child, this was the map of the implantation of the catheter, and finally, it was surgery. It was operated on, and it turned to be a cortical dysplasia type 2A. The electrodes are so implanted and show you the network, epileptic network that will provoke seizures in these patients. What about tumors? These are different kind of tumors. It has benign tumors, the so-called long-term epilepsy-associated tumors. They are cortical tumors, or DNET, or gangliomas most frequently. And the problem with these tumors that at least 1/3 of these cases are associated with cortical dysplasia. So if you just resect the tumor, what you see as a tumor, these patients that have long-term epilepsy, only 50% of them will be cured. So you have to go deeper and analyze more deeply these cases. For instance, in this case in the insula, here is the child, left hemisphere, and there was a DNET. Or this another one patient, and you see that even in tumors, you may have the transmental sign, thinking that it was only a cortical dysplasia, but sometimes this this transmental is pseudo-transmental, and this in fact tumoral. So have to be resected in these cases. In children, temporal lobe surgery, we still have medial temporal sclerosis, but only half of the cases. The other half, we have cortical dysplasia and or DNET. They are more frequent in cases like this. What about the outcome of seizures in children after surgery? You see that the experience is quite satisfactory. If you add angle 1 and angle 2, that is rare seizures, you see that the great majority of these cases have more than 70% or more of cases free of seizures. In some cases, as in tumors, as I mentioned, if you resect also the cortical dysplasia associated, you will have more than 80% of seizure-free. And this is the experience that is shown everywhere. For instance, in Cleveland Clinic, showing that there's no difference in the outcome from children and adults concerning the treatment of epilepsy surgery. Another very important aspect and peculiar aspect in children is that you have to rehabilitate these children very, very early. We start normally, typically in the second week of this of the surgery, and even with the large surgeries or big surgeries, as hemispheric surgery, all children leave the hospital walking, and this is very important. So, what was the recommendation from the International League Against Epilepsy concerning the epilepsy centers for pediatric epilepsy surgery centers? Here we are in the south of America, and this was a report from 21 centers, 61 centers that do epilepsy surgery in children. What is interesting in this, I want to emphasize for you, if you categorize these centers by level of care, you see that it's common for children 9 years or older with common etiologies for epilepsy, and the surgery can be done easily. But if you, in small children, 8 years or younger, with more complex pathologies, for instance, hemispheric surgery, Asmussen encephalitis, or tuberous sclerosis, or hemimegalencephaly. So the surgeries are much more complicated, and this will need a complete team of specialists in order to indicate surgery. But what I think it's very important here is that for the first time, the International League is indicated that the pediatric neurosurgeon should be involved in every case. So this is very, very important. In conclusion, epilepsy surgery in children is challenging, and surgery is performing today as early as possible. And for complete assessment, you need a multidisciplinary team working in specialized centers. And in my view, the pediatric neurosurgeon is an important person, as an essential role in the surgical decision and planning with all the other specialists, the operatory tactic in these cases. And I cannot leave without mentioning Jim. Thank you.
Thank you very much, Professor Machado. That was a wonderful overview of your masterly epilepsy surgery work. I'm not, I don't do epilepsy surgery, but if I may ask you a question in terms of looking forwards, do you think that in terms of ultrasound, focus ultrasound or thermocoagulation, do you think the epilepsy surgery will become more less invasive? Do you think these focused ultrasound and thermocoagulation, they will have a role to play?
Yes, there's a tendency now in all the big centers around the world in doing this kind of techniques. And I think that there's a special place. I can tell you, for instance, the difficult cases of hypothalamic hamartoma. The direct surgical technique is so difficult. This connection of hamartoma so deep in the brain is so difficult. We're now using thermocoagulation or laser ablation for these cases with great success. I don't think that you can treat big cases, although it has been tried, cases of hemispheric disease like hemimegalencephaly or others, Rasmussen encephalitis. But for instance, polymicrogyria is another example that is multiple polymicrogyria in children is quite common, and they are bilateral frequently. And if you, by studying with intracranial monitoring, placing electrodes, as I showed in the stereo EEG fashion, you can sometimes see that just one of these are responsible for seizures. And this has been treated with success with any kinds of neuromodulation, as you mentioned. I think there is a place for that. For instance, only the VNS is authorized as a surgery commonly performed in children, not the other one. Other are not waiting for big experience. But I see a future in this difficult case, yes.
Thank you very much, Professor Machado. As always, we'll have new technology and then we will go back, but I think it's all will be complementary. I presume that that's what you will think as well, that these new additions will be complementary rather than necessarily.
That's it.
Thank you. Thank you very much, sir.